بسم الله الرحمن الرحيم الحمد لله والصلاة والسلام على رسول الله. Thank you, chair people. Thank you, Prof. Bishlawi, for this. As the doctor said, we are waiting for it for every year to see our friends here in Cairo. Thank you for the organizers for very kind organization. My mission today to talk to you about the CNS manifestation. ما هو ده مش sorry for this technical issue. This is my disclosures. Look to this slide before I do start my talk, since about the stroke in California, how was the rate, and then since they have started the stop trial in 1999 or 1998, where Miguel was part of that study, has been declined in order that made it very significant. This is what I'm going to talk to you about. I hope I can finish in 20-25 minutes. This is about the rate of and the prevalence of this stroke. والله صجيتني. It's different from a nation to another. For example, in Brazil, it's almost 20% of the sickler they get stroke, while somewhere in Eastern province in Saudi Arabia, it's not a major problem. It's only 1%, and when we compare it to Medina in Saudi Arabia, it's 10%. And this is related to the haplotype and the nature of sickle cell anemia. Silent infarction, where we discover it accidentally when we do MRI or CT scan for something different, and it's a major one. It's almost 1/4 of our patient sickle cell anemia, they have silent stroke. Couple of weeks just I have discovered one when we have done the CT scan for totally something different. We found that he had an old infarction, and he is complaining of nothing and living normal life. Neurocognitive outcome, I'm sorry. Second stroke, this is very important. That is why we are doing something for those patients whom they develop first stroke, because 70% of them, they will develop second stroke. So we need to make some measures, either chronic blood transfusion, which is the standard, or something else, which I'll come to speak about. Neurocognitive outcome in sickle cell anemia, whom they have stroke, it is much lower than those sickle cell anemia whom they have silent stroke. But again, those whom they have silent stroke, they are lower than sickler whom they are normal, and they are even lower than the control normal population. And this is the slide where every one of you knows about the pathophysiology, and Prof. Mona or Kulthum اتحفتنا pathophysiology made my life so easy, and this is again the same slide she presented. This is the couple of SNPs where it is related to the stroke, which is very important. And I remember 10 years or 12 years ago when that paper has been published, and we had a meeting in Paris. At that time, we thought that in 5-year time, the SNPs for the stroke, it will be standard part of our evaluation and investigation and routine investigation for sickle cell anemia. Now it is almost 12 years and still we are waiting for that. But it is coming not only for the CNAs but for all the others where the GWAS, now it is very cheap enough that we can do it for every patient, not only sickle cell anemia. And you know which SNP that these patients have. It is the same like transcranial Doubler. It is a predictor. So this is genetic predictors for the complication in sickle cell. And this is the circle of Wells 30 years ago since we were medical students. This is for me. And you are quite aware, Prof. Monashi spoke already about the blood vessels of the CNS and which one is manifested more. Look into this slide, it's comparing adult and pediatric. In pediatric age group that the infarctive stroke is more common than the hemorrhagic stroke, while in early adulthood hemorrhagic stroke is more common, and in late adulthood elderly people again infarctive stroke is more common. This is relating to the genotype, and SS sickle cell anemia has the higher rate of the stroke compared to SC or S beta 0. There is a couple of risks carried to those patients whom they may develop a stroke accordingly. It's again some sort of predictors, but it is mild predictors. For example, those patients whom they have TIA, chronic anemia, we have noticed that adults whom they have chronic anemia with hemoglobin of 7 to 8, they have higher rate of the stroke than those patients whom they have hemoglobin 9 to 10. Acute chest syndrome, it's linked with the stroke, higher rate of the acute chest syndrome, hypertension, silent stroke, nocturnal hypoxia, where we need to measure that not only for the stroke but for the well-being of the children, the thing which usually we are missing. Nowadays, what I do, I ask them to buy the pulse oximeter at home and to measure the oxygen and report it in the next clinic. If there is something, I refer them to the pulmonologist. We will continue about the risk factor. Of course, children, they have higher rate of the stroke than the adult, and family members with family history of stroke, it's a factor. Particularly, they are sharing the same SNPs on genetic basis. As I said, acute chest syndrome, repeated seizure, bacterial meningitis, periapism is a risk for the stroke. CAR haplotype, again, it is one of the risks for the sickle cell anemia. Splenic dysfunction, one of them. And this is the principle of the transcranial Doubler, which is again for its carrier risk. How we diagnose this patient? First of all, clinically, usually I do teach my resident, whenever you are in emergency room, sickle cell anemia came to you complaining of something may relate to the CNS, start exchange, you will lose nothing, and then do your radiology. It's very important, particularly where I live, it's 10% of them, they will have a stroke. And usually, those patients whom they come to us with a stroke, either the delay at home or misunderstanding from the ER physician, and they are delaying the exchange to do CT scan or MRI, or let us wait for the morning to do automated, and so on. So this is some sort of not acceptable. We don't have to have all of those clinical criteria to diagnose a stroke. Some of them, they may present only with headache, nothing else. And when you do CT scan or MRI, you will find that this patient has had a stroke, paresthesia, hemiparesis, hemiplegia, seizures, and so on. It is some sort of presentation, but it is not the case always. Transcranial Doubler, it is preventive measure diagnostic setup, but you may use it even for stroke, and you will find during the stroke the stenosis is higher. I'm talking about pre-exchange. CT scan brain, the conventional one, usually it will show the stroke probably 72 or 48 hours after. The new technology of CT scan, it will show it within 24 hours. And of course, MRI is the best tool to diagnose stroke during the acute phase. MRA later on, we need to do it to look into what blood vessel is injured, angiography. PET scan, the hospital where they have this facility, which I don't, it is very useful test which pick up the stroke once it happened. New technologies of MRI also there. This is one of my patient long time ago, and okay, balash pointer. It is clearly that there is on the slide on the left side, right side, big stroke. You can see it. This one here. It's big one actually, and this patient, when he presented like this. Exchange has been done. He kept on a transfusion program and no hydroxyurea at that era, and we could reduce his hemoglobin is really below 40%. This patient now he is functioning normally. He left with no sequelae. So good care, it will lead that you preserve the function of those patients. Earlier on, probably the younger generation, they didn't hear about it. Simple transfusion were part of the management, and this compare the simple transfusion to the exchange, where exchange doing much better than the simple transfusion in case of the stroke in sickle cell anemia. Again, when we look into the transfusion, chronic transfusion program for those patients, we will find out that those whom they have transfusion, they have less recurrent compared to the people whom they left without transfusion program. We tried the best, as Prof said, that to choose the blood we are going to give to those patients wisely, otherwise they may develop the alloimmunization, and you will be stuck with those patients to reduce the infection rate and so on. Your aim is to keep the hemoglobin is below 30, but probably most of us below 40 is an acceptable way, and some people they keep it below 50. Now, still the discussion since 20 years ago for how long we are going to keep those patients on transfusion. For life, some people they say it's only enough for up till the age of 18 or just for 3 or 4 years. So at that era, the conclusion came that blood transfusion should be kept for life, and to keep the hemoglobin is below 30 as an aim. And you don't need to stop those patient from transfusion. You need, of course, look for the function, rehabilitation, physical activity of those patients during this era. Let me talk a little bit about Transcranial Doubler, which came to the market in 1999 by Adams. When they have shown in that study, those people whom they have high velocity, it depends, of course, the technique you are using. So the numbers, it is not going with each machine. So those whom they have more than 200 centimeter per second, this is very high velocity enough that those patients in high risk, and you need to do something immediately, and you don't wait If you want to repeat it just in a couple of weeks, it's okay. Otherwise, you need to go ahead. The other one, which is conditional, they are doing better, of course, than those. They have more than 200, and those patients with conditional, you may keep doing the transcranial Doubler every 3 months, and if it's still the same, so you need to keep those patients on chronic transfusion as if they are stroke. And of course, those whom they have less than 170, they are normal people, you need to do nothing for them. Step 1 trial, they have compared about those patients after high velocity on transcranial Doubler, whether those patients need transfusion or not. So step 1 trial, they have done it, and they have found that transfusion program for sickle cell anemia patient with transcranial Doubler, which is more than 170 or more than 200, they are doing much better regarding stroke development than those whom they kept without transfusion. Then they thought, do we need to continue transfusion forever like they have a stroke, particularly that they are not stroke, they have only a high risk for a stroke. So they have done the step 2 trial where to continue or not to continue, and once again they have found those whom they continue transfusion and keep their hemoglobin S low, they are doing much better than those whom they have stopped their transfusion after 3 years. So the conclusion was continue blood transfusion for life like the stroke. This is transcranial Doubler of one of my patients, and this is the same patient angio which show middle cerebral artery occlusion. Now let us move to the switch trial. The switch trial, they were looking into something else, that those patients whom they have stroke and they kept on the transfusion program for at least 18 months, and then they will randomize them into either to go for transfusion plus deferrous, and the primary endpoint was the iron overload, or to go for the other arm, hydroxyurea plus phlebotomy, and again to reduce the iron overload. This study has been terminated early because in the arm of hydroxyurea, a couple of patients, or it's 10% I think, they have developed stroke, so it has been terminated by the authority for that reason. Though from the iron overload point of view, it was non-inferior in this regard. But the recommendation came that we don't need to replace the transfusion with hydroxyurea in a stroke patient on transfusion program. While Twitch study, it's non-inferiority trial, but in both people whom they have high risk for stroke measured by transcranial Doubler, and they have found that after 4 years of transfusion, they will shift them into hydroxyurea, and they have found that this way of management could reduce the rate of, or actually non-inferior compared to the transfusion, and yet it has not been came to the guideline, but the conclusion was it was okay to shift to hydroxyurea alone after 4 years of transfusion. And on this table, on this table, which is very difficult to read even for myself, I am near to, but it has been found between the two groups there was no difference, hydroxyurea or transfusion in any regard, and the p-values, all of them were not significant. So I believe that they have mentioned something about this issue in the last guideline, ASH guideline for CNS manifestation, and I believe it will be part of our practice in the coming guideline. Transplant, I think most of the center nowadays, once you are a patient of sickle cell anemia develop a stroke, they will go for transplant, and only you are waiting for the preparation for the transplant. You are doing the transfusion program, and once he is ready and there is a donor, you will go for transplant, and you need not to wait. I'm not sure about this program here in Egypt, but we are starting in Saudi Arabia, and I think we are progressing. The problem that number of beds available for sickle cell transplant. To prevent the stroke, first of all, we need to educate the families about stroke. You don't need to wait for the baby till have frank stroke, then bring him to the emergency room. They need to come early. And we need to educate our ER people about stroke and how detected, and the radiology diagnosis is not the most important one. We need to do transcranial Doubler every 6 months or every 12 months for all of our patients. It is easy, non-invasive technology, and it is very predictive for stroke. And I believe the studies actually made all over the world has shown that how far transcranial Doubler could reduce the stroke rate. In Medina, we had an experience in this regard. We could reduce the stroke to maybe 1% or so since we have started transcranial Doubler. Over in the middle 2 years, we couldn't do the transcranial Doubler for radiology issue, and during those 2 years the stroke rate has been increased. So transcranial Doubler is very important way to measure or to predict for stroke, and should be done for every patient. Thank you.